We are so thrilled to be providing this webinar on fertility preservation, what providers need to know. My name is Kelsey. I will be your webinar host and the coordinator of background details. As soon as we get started with the slideshow, I will go ahead and turn my video off and mute myself and let our amazing physicians take over. So I'd love to introduce Dr. Roohi Jeelani. She is one of our amazing Chicago providers. She sees patients both in the city and in the suburbs. Dr. Ellen Hayes is one of our physicians up in the Milwaukee office. She also sees patients in Milwaukee, Oconomowoc, and in our West Loop office. And then our newest physician, Dr. Erica Louden, thank you so much for joining Vios. We are thrilled to have you as a provider in our Chicago region as well, seeing patients in both the city and in the suburbs. So thank you so much for joining us. We're so excited to hear from you. Dr. Cooper will be joining us in just a few moments while she finishes up with a patient, but she'll hop on here. Oh, speak of her right now. She must have heard me. Her ears were burning. Dr. Amber Cooper, everyone. What an entrance.
So sorry.
No, thank you so much for joining us. Dr. Amber Cooper is one of our amazing physicians in our St. Louis region, seeing patients both in Southern Illinois and in the St. Louis area of Missouri. So thank you all, panelists, for joining us. I'm going to go ahead and turn off my camera and mute myself, and we'll get started. Oh, just kidding. I'm going to tell you about our core values. So we at Vios Fertility are guided by these 4 tenets. We are guided by our vision, innovation, teamwork, and passion. Our passion is providing excellence in fertility care. We strive each and every day to be the best we can as individuals and as a care team. We really believe in patient-centric care, and all of our providers are here to tell you a little bit more about what that means to them.
So I'll start. My name is Dr. Roohi Jeelani. Thank you, Kelsey, for the very kind introduction. And we'll talk about our Center of Excellence for Fertility Preservation and Oncofertility. They both go hand in hand, and they're both equally important. And the purpose and our mission is to provide state-of-the-art care for any patient seeking reproductive health and preservation. So what does that actually mean? Fertility preservation, whether it be for social egg freezing, for reproductive aging, or for oncofertility, and they're basically interchangeable. So you're freezing to have potential options for future children, whether it be due to age or a gonadotoxic agent such as chemotherapy. The goal and purpose of this is to maintain our reproductive health for patients who receive medical treatments that may affect your gonads, such as your ovary or sperm production. So then we preserve their gametes for future childbearing. And if you're doing it for age-related fertility preservation, we'll explain why, and the process is very similar. So what is the term oncofertility? It's a combination of 2 different fields. So oncology, which is a study of cancer, and fertility, the capacity to have offspring in the future. So you combine the 2, it's balancing fertility preservation. So balancing your reproductive organs in the setting of cancer. So it basically bridges the 2 fields. So patients who are currently undergoing any cancer diagnosis, and I'll preface that with saying it's not necessarily just cancer. There's a lot of rheumatological diseases that use gonadotoxic agents like chemotherapy to treat autoimmune conditions as well. So this applies to them as well. So what is fertility preservation? Fertility preservation is delayed childbearing for multiple reasons, whether it be for career, education, lack of a partner, just not ready to have a child, or not in that financial place where you'd like to be to have a child. And we also have patients that are transgender. So prior to receiving any definitive surgery or hormone therapy, if they want to have preserve their future fertility or have offspring. What does that mean for them? Or patients who are seeking us out, which we see more and more, I'm sure my colleagues will agree, because of a family history of premature ovarian insufficiency, or knowing that their sibling or anyone in their families suffered multiple miscarriages or early menopause, then they can seek us out for the very same reason as somebody who would be undergoing any gonatotoxic agent. So why is this important? Because as females, we're born with millions of eggs, about 2 to 3 million at birth, and then they disappear over time. Just for example, as soon as you hit puberty, we have about 200,000 left. Although that seems like a lot, that's a huge drop.
So
Dr.
who's
Yates.
our ideal candidate? So this is all patients preparing to undergo a gonatotoxic treatment such as chemotherapy, radiation, or surgery. Not just patients with cancer diagnosis, as Dr. Jeelani mentioned, but those with autoimmune diseases such as lupus or vasculitis. And this is very important for our patients to be aware of, because there is coverage for them now since 2018 when the Illinois House bill was signed, which mandated coverage for medical necessities for fertility preservation services. So for any patient that's undergoing any treatment that would directly or indirectly cause infertility, it's important that they be connected with a REI so that we can help them think about the future. For our fertility preservation patients, these are women social freezing, doing it. Most people say less than 35 or younger. I actually start talking to patients at age 30. For oncofertility, once again, this is ideal for patients prior to gonatotoxic treatment. So chemo, they're having radiation, or even surgery that we know may compromise the blood supply to their ovaries. Unfortunately, this is currently underutilized despite it being mandated for patients, especially in Illinois. SART data has showed that there is now 13,275 patients that have done embryo banking as of 2018 preliminary data, and it's always a 2-year delay in that, so we won't know for this year for another couple of years. And then oocyte preservation or oocyte banking in 2007, it was 9,607. So that is a 38% increase in egg freezing. And then we had a 74% increase in embryo banking. However, a lot of patients still feel like they have never got appropriate counseling when they were seeing their chemo doctors or having radiation. And a lot of physicians during studies have suggested that they just didn't feel comfortable about the topic because they hadn't had enough education on it themselves to broach that conversation with their patients. So we want to make sure that we increase the rate of surveillance and getting the multidisciplinary approach where all of the doctors are on board with these patients before they undergo their treatments. Furthermore, this is very vital because we know now, because of increased therapeutic options and how much our technology has changed, that people are surviving their cancer diagnosis. So there are currently more than 135,000 people under the age of 45. More than 70% of those are age of reproduction. And so taken together, there are more than 270,000 survivors of pediatric cancers and more than 1 million survivors of young adult cancers in the United States. Thus, the prevalence and the need for this is great. And this is just a slide that shows from the US Census how many women of reproductive age and how many of them are childless. Once again, just to take home point of that this is an issue. So if you look at the first area where we have the women 15 to 50 years old, obviously we don't want our teenage girls having babies, but look at the percent childless in that category for those who have never married, and that's 75.8%. Women who have been married, that's a 17% that are childless. And we wonder why, what's the indication? So we can help that number decrease by offering fertility preservation, whether it's for social reasons or if it's for medical therapy treatment reasons. So the need, once again, for fertility preservation. Fertility is impaired following surgery, can be chemotherapy, depending on your treatment, and radiation or radiotherapy when there's greater than 10 gyres of radiation exposure for treatment of cancer. This is damaging to the ovaries and testes, and it is drug and dose dependent and related to the age of onset of treatment. Total body, abdominal, or pelvic irradiation may cause ovarian, not only ovarian damage, but uterine damage depending on the radiation dose.
All right, my turn. So to just kind of come right off of that, leading to really why is the cancer therapy, but why we really care is both chemo and radiation, is how Dr. Jeelani described, we are born with a number of eggs and we don't make eggs over the course of time. And I always say it's like we have a jar of jelly beans and we lose a handful every month. So without the ability to make new eggs, anything like chemotherapy or radiation can damage those eggs. In the ovary, our small primordial follicles sit around the cortex, the very edge, the outer millimeter, which is why we say when we operate, we like to save some ovarian tissue. So any chemotherapy that's delivered to the ovary through the blood vessels can damage growing follicles, which in turn can recruit other follicles in faster. Radiation can damage the outer cortex. And there's a lot of debate on, can you shield the abdomen and pelvis, which may help, but there may still be some spread. So the bottom line is it damages the follicles, either through delivery through the blood or direct damage. Over time, it can cause fibrosis, and it can cause early ovarian aging, early menopause if it's before the age of 45 or premature, or primary ovarian insufficiency if it's before the age of 40. Next slide. So it's a little tricky when you counsel women on their exact risk. You can have a young teenager with, say, a solid tumor or lymphoma that maybe if they have ABVD therapy, then they may do okay. It may damage a small amount of the egg pool, but they may actually have a fairly long reproductive life. On the other hand, someone getting more aggressive chemotherapy may damage the egg pool pretty rapidly. It is very hard to predict, which is why, as Dr. Louden just said, you should really counsel all patients and give all patients access to fertility preservation, or to at least have that discussion. However, it's important to understand the age of the patient matters. If you start with a larger pool, you may be left with a little bit of a pool. The egg pool to begin with, a starting AMH or antral follicle count may be able to help. But given our ability to freeze eggs fairly quickly, it's really worth talking to almost every type of cancer or autoimmune disease patient before they face cytotoxic therapy. Amenorrhea rates, if you look at cancer publications, if you look at publications looking at the, quote, toxic effects of chemotherapy, they often use amenorrhea as an outcome. It's important to remember that just having menstrual cycles does not equal fertility. And a lot of chemotherapy drugs that didn't have amenorrhea in the studies may actually still damage fertility a pretty significant amount. So meds and radiation that actually have high amenorrhea rates really, really will damage that egg pool. But even medications that have low amenorrhea rates in some of these studies may still damage AMH, may damage the egg pool, and you may see that down the road. Next slide. So, where do we sit today? We have more successful oncologists and radiation oncology, and even sort of these less invasive, as they call them, radiation therapies, still can be damaging. But the best part is that these patients survive longer. And so you've got your pediatric cancers who need help over the course of their life because they have such a high cure rate. And you have better survival in reproductive age women and reproductive age men to cryopreserve sperm as well. On top of that, you have more women pursuing careers and delaying childbearing. And that's an important thing to consider. And so I think, going back to Dr. Louden's point, you really have to talk to patients about it. And oncologists, probably only about a half of oncologists surveyed actually talk to patients about it. They feel like they give them too much information at once, and it's hard to bring up infertility as well. But data shows these patients are more thankful in the end if you do have that conversation. Next slide. So where do we sit? So ASCO and ASRM both really, really urge specialists to start the conversation. And to the general OBGYNs out there, I encourage you, if you're the first one to diagnose a breast cancer or cervical cancer and endometrial cancer, before you even send them to the oncologist, initiate that conversation. send them to the REI at the same time to start that conversation as well. Oftentimes for cancer patients, we are getting these referrals from the oncologist directly, but there are a lot of ways they can enter our system. But really, both ASCO and ASRM pleads with providers to initiate the conversation. Data shows that even patients that have the conversation, should they choose not to preserve fertility, actually feel much more complete that they had the option to do so. Next slide. Ellen's turn.
All right, I'm up. So I'm just going to briefly discuss some of the fertility preservation options available. So including embryo cryopreservation, freezing eggs, freezing ovarian tissue, ovarian suppression using medication, using GnRH agonists, and also cryopreservation of sperm. So embryo cryopreservation is obviously the most widely available, well-established way to preserve fertility. It's tried and true. We've been freezing embryos for years and years. This is a good option for women who have a partner, or for those women who feel more comfortable creating embryos and using donor sperm for that purpose, because obviously we need to have sperm to fertilize the egg. And the requirement is that these patients be post-puberty. So these can be teenagers, and these can be women, anyone of reproductive age, as long as they're post-puberty. It's required that we stimulate the ovaries, so similar to an IVF cycle. So the ovaries need to be responsive to gonadotropin injections to recruit multiple follicles in order to get these patients to egg retrieval and have sufficient eggs to create embryos. And in most labs, the embryo survival rate is going to be around 95 to 98%. And then on the other hand, we have oocyte or egg cryopreservation. So again, in order to obtain these eggs, these patients have to go through ovarian stimulation. And I think Dr. Loudon's going to kind of depict that in a later slide. But we need to have girls post-puberty or women. And this is a great option for women or girls who do not have a partner and do not have a wish to use donor sperm to create embryos. We, in the last several years, have gotten very good at freezing eggs, and now egg survival rates post-thaw are in the range of about 85 to 90% in most labs. Not every lab is comfortable or able to freeze eggs well, so we want to, encourage people to find that out before they're referring to certain practices. At Vios, we have a lot of experience freezing eggs, thawing eggs, and using those eggs to achieve pregnancy. And the reason that egg freezing and egg survival is so drastically improved and is obviously in the last several years no longer investigational is because we use a process called vitrification, which is a very rapid freezing process and rapid thaw, and this results in very little damage to the oocytes. So these eggs survive the process really well. Our goal in general, and this is just a goal, is approximately 15 eggs. But essentially for women who have little time and only have time to get one retrieval cycle completed before they need to start their cancer treatment, we'll get what we can get and we'll save the eggs for them. It's also possible now, and we know that patients do just as well with a random start to their ovarian stimulation, so we don't have to wait until they start their next menstrual period, so that shaves some time off the process. And they also do well having 2 egg retrievals within the same month or the same cycle in order to bank additional eggs if needed. So there's also the option of cryopreservation of ovarian tissue. And this is a good option for women who do not have time to go through ovarian stimulation, because that does take approximately 2 weeks. Or a good option for girls prior to puberty who we can't stimulate and perform egg retrieval on. At this point, there's been well over 100 children born from tissue that was initially frozen and then auto-transplanted. And we really don't know the success rate per se because the statistics aren't being kept necessarily as accurately as we would like. So the success rate is difficult to pin down, but we know that there have been many patients that have had successful pregnancies from this type of tissue preservation. The other benefit to ovarian tissue versus freezing eggs or freezing embryos, which are solely for the purpose of fertility, obviously, is that this tissue can be auto-transplanted to restore hormonal function in women who otherwise would go through early menopause or to induce puberty in age-appropriate cancer survivors. Next slide. And then another option for reproductive age women who may not have time to go through an ovarian stimulation process in order to obtain eggs or embryos is treatment with a GnRH agonist. So for instance, Depo-Lupron. So ovarian suppression has been found to prevent the iatrogenic loss of ovarian reserve using these medications, so inducing a medical menopause. And what we found is that premature menopause post-treatment, thank you, is significantly lower for the women who undergo ovarian suppression prior to their cancer treatment. And you know, the question of how much this preserves fertility, there are mixed studies, but you know, preventing or lowering the risk for premature menopause is not an insignificant event in and of itself. And so the fact that they're menstruating does not necessarily mean that they'll have fertility or be able to achieve pregnancy easily or on their own in the future, but it is a sign that we're helping to maintain their long-term endocrine health.
So the fertility process with ovarian stimulation is expedited in cancer patients. We can typically get this done within 2 weeks, the maximum 3 weeks. Next. And this entails us doing a medication start. We typically use a random start, so we don't, once again, as Dr. Has mentioned, we don't have to wait for the start of the menses. We can start whenever the patient gets to us, which we want to see these patients ideally within 24 to 48 hours of you sending us a consult. The patients are counseled about based on age and AMH, and we begin stimulation as soon as possible. So it's essentially we get them, we do a blood draw the same day of everything they need, and they start ovarian stimulation with monitoring. And that entails us giving them injectable medications for up to 14 days to stimulate follicle growth. During those 14 days, they're coming to us maybe 2-3 times a week for us to do an ultrasound and monitor the ovarian response and make sure the follicles are growing. When they get to the critical size where we know that most of the eggs we'll be able to get are mature, we give them what's called a trigger shot. That trigger shot goes on and continue to ripen the eggs and get them prepared for us to do a small surgical procedure that occurs 36 hours later. And that's 1 or 2 days later, while they're asleep under IV sedation, we can aspirate out all the follicles or eggs that we were able to mature during the cycle. And then we do vitrification, which has greatly improved the survival rate of eggs. And it's essentially a flash freeze of eggs to a glass-like state before storing them in cryopreservation tanks. And at this point, we turn over the patients back to their physician. A lot of questions comes up about the medications, though medications, if it is something that is a cancer that is hormone sensitive, we don't have to use medications that are going to make their estrogen super high. So we just are in constant communications with you as their primary doctor in this.
So what to expect? From a provider perspective, you want to know what should you be expecting from the minute you turn over the patients. So typically we ask good, like Dr. Louden said, good communication. If we can, when you send us the patient, if you can give a letter of clearance stating that this patient has X, Y, and Z cancer, and we typically ask for about 2 weeks for stimulation. Once we get that letter, we typically, how it works is that we have a liaison, as you guys do, a nurse navigator, that then coordinates the patient's care. So they do appointment with us, that's a history and physical, on the same day as they do all of their lab work and their ultrasound. That ultrasound will give us a predictor of their current ovarian reserve, as well as the follicles that are at bay for stimulation. Stimulation takes about 10 to 14 days for egg freezing or IVF if we're creating embryos if they're in a relationship. So they monitor every other day. While doing that, it's important to understand and know that they can still continue working on the chemotherapy aspect, not necessarily getting chemotherapy, but they can get their port placement done. They can do further testing. If they need PET scans and MRIs, they can continue doing all of that. If they're doing radiation, we can do egg freezing and creation of embryos while they're getting their radiation done. So depending on the type of cancer, it's important that we coordinate and get a good care plan in place. As soon as we do the egg retrieval, they can start chemotherapy the next day if need be. And then like Dr. Louden said, we do typically put them on oral medication to help lower their serum estrogen levels as well. There's really no hard and fast data to say if that really helps in the outcome, but I know as practitioners, that does help us make us feel better. But it does not make, it's important for them to realize and important for us to know that doing this for a short duration does not worsen their cancer and does not cause any reoccurrence when they use these eggs in the future. So who should we be offering this to, whether it be from an oncology perspective or a fertility preservation perspective? It's offered to females of all reproductive age. This will not affect your future fertility. So one of the most important questions that these patients ask is, do I have to use them? What if I want to try naturally? Then you can. We're not taking out all of your eggs. We're only taking out the ones that have been activated for that cycle. This will not reduce the number of eggs for your future. It's kind of what's activated, like a champagne glass, it bubbles to the top. Whether you sip it or you use it, it fizzles down. So you would lose them that month. This is a great option for anyone looking to build their family in the future and just not now. We have very rapid care here at Vios. We do have for our oncology patients, they know that they get same day appointments, blood and ultrasound the same day. We do have a lot of grants that we do work with to help with medications and kind of help facilitate. Illinois is a mandated state when it does come to cancer therapy. So it does mandate coverage of a lot of fertility, oncofertility. And some of the plans also include egg freezing for not our cancer patients. And then most importantly, here at Vios, we have a tank called the Tomorrow Tank, where it uses artificial intelligence and a robotic arm to kind of help tell you where your eggs and embryos are frozen, what the exact slot number is. So it has an RFID attached to it, kind of like the credit card RFID that's attached to it. So you will eventually have an app which will tell you at what temperature, where your embryos are frozen. And something cool and interesting, that it's protected by the National Guard. So if there is ever a national disaster or anything, you know your embryos and eggs are frozen in a very safe environment here at Vios.
So just to add to that, what Dr. Jeelani just said, you know, Illinois being a mandate state and having some of those things, Missouri, Wisconsin, some of these states that are not mandate states, we actually at Vios have really made it a key priority to offer pretty dramatic discounts to egg freezing patients, and even more so to oncofertility, you know, cancer type situations and autoimmune diseases. So even in non-mandated states, and as Dr. Jeelani just said, on top of that, there are a lot of medication programs that we can get the vast majority of their medications provided to them in most cases, which I think is awesome. So kind of to end this segment today, I'd like to kind of talk about ovarian aging on a general kind of big picture, because that's what this is about. I mean, one of the reasons we preserve eggs in cancer therapy situations, autoimmune therapies, but also genetic conditions, and even sort of situations where we don't even understand environmental exposures and enhanced loss of the egg pool, is really because we have a finite egg pool and we don't make eggs. And, you know, on this slide here, it's important to understand, you know, I always tell patients, when you're a 20-week fetus, you have maybe around 3 million eggs. When you're born, about 1 million. When you start puberty, maybe around 300,000. It's pretty wild to think that we lose over 90% of our eggs before we care to use them. I tend to say from puberty to menopause, it is that slow rate of loss over time. We think something magic happens on our 35th birthday and, we wake up and we have that stamp of AMA, but really the ceiling doesn't fall in at 35. There's a slow, steady increasing loss over the course of time. And, we see probably a little bit enhanced in the later 30s. So as Dr. Louden said, it's important to really talk to women about their egg pool, even in their early 30s, to understand what it looks like, to understand we do use tools such as AMH and antral follicle count to understand the quantity of the pool. And you can go to the next slide. In ovarian aging, this is something, I use when I talk about ovarian aging on a big picture scale, especially for OBGYN providers out there, to recognize that there's a spectrum of aging that we actually think recurrent miscarriage may be part of. That, when you look at other things, it's important even in recurrent miscarriage to look at the egg pool, not only because there's some theories out there that we may lose our better eggs first, which is a little bit controversial, but discussed. And, when we look at genetic testing of embryos, we may be starting to see that, but that as you start to have ovarian aging, you have hormone dysfunction that may lead to recurrent miscarriage. So it's a little tricky there, but over time, what happens in ovarian aging, and that's why going back to what we said, just having menstrual cycles after cancer therapies does not equal fertility, because what happens first is you may have an increased miscarriage rate, you may then have lower egg pools and an inability to get pregnant. Then over time, cycles go from shortening to spacing out and eventually going away. Next slide. And so, this is where kind of what do patients perceive? They go from having regular cycles in ovarian aging to slightly shorter cycles. And I think it's really important to tease out if a woman tells you, hey, my cycles were always 31 days, but now they're 27 days. That's actually a significant shortening of cycles. To ask about earlier ovulation, pre-cycle spotting for several days is a sign of ovarian aging. If it gets more progressive, they eventually then have longer cycles, they stop ovulating, and they eventually go away in that spectrum. Next slide. So really, ovarian aging can be normal. And so while we talked a lot about cancer therapies and fertility preservation, because that's a very important one that we don't want to miss, it's really important to understand, that if you have conversations about normal ovarian aging with women, they may understand even more pathologic ovarian aging in situations that we may look to preserve fertility in that way. There is a movement across the United States to move away from terms like social egg freezing, to really say this is medical egg freezing, that there are underlying indications. There may be that egg pool is a little bit lower, and we don't really know why. Is it underlying genetic indication? Is there environmental exposures over time? There's a lot of exciting things we have to talk about with regards to nutrition, inflammation, environmental exposures, obesity, and we have a great planned webinar next month on ovarian aging. So we really would love for you to join us then. So it's important to really think about ovarian aging and fertility preservation, but obviously there's a huge need for fertility preservation in cancer, autoimmune, genetic patients, but really just look at these patients' ovarian reserves. That's sort of my plea to consider an AMH. And if you don't know how to interpret AMHs, please call us. We can help talk to you about it and talk to patients about it anytime. So we will take questions at this point.
And really quick before we do a question, this is Dr. Louden. I do want our guests not to feel this is slander. We do take care of males. So males do go through gonadotoxic treatments and have autoimmune diseases. We have an in-house urologist, Dr. Pagani. So definitely if you have those males before you start treatment, consider us too, so that we can also talk to them. It's a lot quicker for them. It won't take 2 weeks. We'll get it done.
Awesome. Thank you so much, Dr. Louden, for bringing up that very important point. To all of our guests tonight, feel free to drop any questions you may have jotted down during the presentation into the Q&A box. To get started, one that we had here is there an ideal age for fertility preservation in both men and women? That one is up for anyone. Any doctors want to take that one?
I'll jump in. I'll make a comment there. I think one of the things, it's a really, really tricky but good question that I think we get asked all the time. You know, if you use the literature from the donor egg population, success rates are probably best under 33 when you really look at outcomes per age of the egg. That being said, there's a small decrease after that, which is why I think Dr. Louden mentioned, even she talks to patients even kind of in their early 30s about that. You know, I think that at no age do you want to consider it a lost cause, because I think it's important to have the conversation, do the ovarian reserve testing, and really have conversations about what those mean. But preferably at least mid to earlier 30s, if at all possible. But there is room in later 30s for women. Age of the egg really drives success rates more than anything. Age of sperm, men make sperm every day of their life, you know, from producing a sperm in a testicle to seeing a sperm in the ejaculate takes 75 to 90 days. So that's why we don't pick on the age of the man as much as we do the age of the woman. Men can fall to pregnancies in their 40s, 50s, 60s, 70s, even beyond if everything's working well. There is some concern with things like autistic spectrum disorders and potentially some imprinting with increasing paternal age as it gets to higher levels of age. So I would say still probably 40s and below, maybe a little bit better. But these are really tricky and good questions, and one that I think we will continue to see evolve in the literature as we see outcomes.
And I would like to piggyback on that because I'm an advocate for us not forgetting the boys. With those boys, if you know you've had male patients and they have been on anabolic steroids, testosterone is a contraception for men. So if you know you have somebody, a male patient who has been exposed, or you're thinking about starting on testosterone, once again, send them to us because that may be a candidate for fertility preservation, or if they have any medical complications, because obviously just like for us, any dings to their medical history will also potentially affect their spermatogenesis, and so we would like to see them earlier than later.
Awesome. Thank you both for those answers. Kind of building on that question, what about a lower age range for patients, especially with oncofertility and our fertility preservation for transgender patients before going through any sort of hormone therapy or gender affirmation surgeries? Can you talk a little bit about the lower age range?
Take that. So younger, the better, like Dr. Cooper and Dr. Louden said. We always advocate for patients to, if you know you're not in a place where you want to have children, you can have children in the next couple of years, younger eggs are always better. With fertility, age is the most predictive factor. So it's not a bad outcome. The reason why we don't say go freeze your eggs at 21 is because likely by the time you find a partner and you're ready to have a child, you'll be in that childbearing age. So if you, going back to your question, Kelsey, if you are going through a gender affirmation surgery, and if you're looking for that, then yeah, before that surgery or before any exposure to any hormone therapy such as testosterone, like Dr. Louden said. But the reason why we say early 30s is because when you look at it, when you look at the studies, they look back and say at what age when the eggs were frozen did the patients go back and use them, and they were 35 to 37, because that likely meant you were not in a position to have a child, and by the time you got around to it, you crossed that 40 barrier, or early 40s. Those are the patients that likely were to use them. So that's where that number came from, that mid to early 30s, not necessarily because there's anything wrong by freezing them earlier or later.
And then to add on, for those patients who, you know, you may have who are going to do gender reassignment surgeries or start hormone therapies, the data is kind of not controversial, but conflicting. Some say to start before they undergo such things, but recent studies have shown that even after, say, a female has been, or a trans male has been on testosterone, they still can be stopped off of their testosterone and undergo stimulation and have future pregnancies that have not, to date, with our limited data, show any negative outcomes on those pregnancies. So right now, I still would prefer to see them before the testosterone, but if they happen to have already started hormones, it's not a problem.
I was going to add that even in pediatric patients, because I've done a fair amount of collaboration with the children's hospitals, you know, you can stimulate a young girl's ovary if she's post-pubertal. Post-menarchal is probably preferred, if at all able, but you can stimulate a young ovary as long as sort of puberty has progressed. Early puberty, it does take a long time and it's more difficult, and that's where the more controversial ovarian tissue freezing situations come up.
Awesome. All of that was incredible information. One last question I have, not through the chat, but another question that we've been talking about is, how do you recommend an oncologist bring up these sensitive topics with their patients? They're already counseling through a cancer diagnosis and talking about family building and fertility preservation. How do you recommend navigating that conversation?
Well, in my experience, many oncologists have now kind of built that into their normal initial consultation, whether it be with them per se or with the nurse navigator that kind of assumes coordination of that specific patient's case. So I really think that, you know, although it is sensitive, it's really important. And over the years, I've obviously seen and spoken to a lot more women planning cancer treatment than those who pursue egg or embryo freezing, but I've never spoken with one who was sorry she had the conversation with me. Everyone is very appreciative. And, you know, it's certainly more difficult when they come back after the fact and they have compromised ovarian reserve or ovarian failure. But even the patients that come and see us ahead of their cancer treatment that decide not to proceed with fertility preservation, they often have questions. Well, what if I do go into ovarian failure? What can I do? Can I still get pregnant in the future? And we can talk about things like, okay, you're not comfortable doing fertility treatment right now, but there are options like donor egg or gestational carriers. And knowing all of those things, it can be extremely comforting. So I don't know that it's necessarily at all a negative thing to bring up.
It provides hope too.
Mhm.
Just talking about, I think, oncologists saying, listen, you've got a long life ahead of you. I'm going to help you treat this thing. I'm already looking at your future. I think it's really important for oncologists to realize it provides some sort of a hope in that conversation.
I love that. Hope is so powerful. That's a really important tool to use. What about with, you know, OBGYNs or general practitioners who maybe aren't dealing with a cancer diagnosis, but their patients are approaching fertility with a question? You know, they haven't met the right person or they have some financial concerns about starting their family. What would you recommend in terms of opening that conversation with their patients?
I think it's very similar. I think they go hand in hand. They're both, you know, options to be proactive and think about your future. I think as OBGYNs, we can offer it at any point. Say, hey, where are you in your life outside of this? Instead, you know, at your annual, should we check some fertility markers? And what does that look like for you? And like Dr. Louden had said, a lot of this is genetic. So if you know there's a family history of, like Dr. Cooper was saying, recurrent pregnancy loss, is there a reason for that, or premature menopause? And what can we do to prevent that? And if you're just not ready in a position to have kids, then seek out fertility preservation. I don't think there's ever a wrong time.
And
I agree. Yeah, I agree, Roohi. I think the biggest mistake would be to have a patient who brings it up and is inquiring and then to stop them just solely based on their age, because obviously in all of our experience seeing patients with infertility, it can span, you know, at any age. There are women in their 20s that already have diminished ovarian reserve, and it's very easy to test ovarian reserve. And if your office is not one that's comfortable doing that, it's very easy for them to come and see us just for simple testing. It doesn't mean that they're signing up for any type of treatment, but it's just gaining knowledge and empowering your patients.
Right. And to allude what Dr. Hayes is mentioning, we have a program called Pulse, where if you don't offer those testing or don't feel comfortable counseling after those labs come back, you can send them to us as costs $99 out of pocket. They're not, and we can forward that information to the patient and back to you as the provider. It includes us doing a brief phone consult to just go over that with them, but it is something because you have a better relationship with them. You've taken care of them probably for 10 years, or so you know their family history, you know their relationship status, and so that's a conversation that it can be easily broached.
Absolutely. And Erica, your audio cut out there just for 1 second, but the Vios Pulse program is available to both men and women and includes some basic hormone blood work, an ultrasound and a semen analysis, and a phone consult with a physician for $99. So it is a great option. That concludes our webinar. Thank you all so much for joining us. Excellent information all across the board. Thank you, Dr. Cooper, Dr. Jeelani, Dr. Hayes, and Dr. Louden. If any of our attendees have further questions, the physicians' email addresses are listed here on the contact page. One quick note is there is no period between Vios Fertility and the email. I apologize for that oversight. So you can email them at their first name, last name at viosfertilityoneWord.com. Thank you so much and have a great rest of your evening.
Okay, bye, ladies.
Thanks for joining us.
you.
Thanks for joining us.
Thank you.